Today's presentation is Views and Reviews in Cerebellum in Epilepsy. This session is moderated by Dr. Ramshekhar Menon. The reference article is The Cerebellum in Epilepsy, published in Epilepsia in 2024 November by Christopher Elder et al. Introduction. The cerebellum has long-standing and well-established roles in functions pertaining to neural control of movements, including balance, coordination, and motor learning. And historically, cerebellum is considered as a motor control structure. But it has anatomical properties that points to its relevance to functions beyond just motor control. And cerebellum contains half of all neurons in the CNS, and cerebellar cortex has a surface area equal to almost 80% of that of the entire cerebral cortex. Phylogenetically, the precursor of human cerebellum arose as a small paired nuclei, or called the vestibulocerebellum, in amphibians and jawless fish. Later, the morphology evolved from smooth median spinocerebellum in lower animals to expanded convoluted lateral neocerebellar lobes in mammals. And later, the cerebellar lateral lobes enlarged, even greater than the corresponding enlargement of frontal lobes in Homo sapiens. Coming to cerebellar anatomy, it has a gray matter cortex, the internal white matter, and 4 paired nuclei. The fastigial nuclei, which is placed more medially, the globose and emboliform nuclei, which together called the nucleus interpositus, and the lateral big dentate nucleus. And functionally, the cerebellum is integrated with other brainstem as well as cortex by 3 cerebellar peduncles, the superior, middle, and inferior peduncles, by which it gets connected to the neuraxis. The cerebellum is divided into various lobules by fissures. There is one major fissure called the primary fissure that divides it into the anterior and the posterior lobes. In addition, there is the flocculonodular lobe as well. The worm is divided into 9 parts, and the lateral lobes are also divided into various lobules. The subdivisions and functions based on the phylogenetical that is, initially phylogenetically, it was divided into archicerebellum, paleocerebellum, and neocerebellum. The archicerebellum is composed of flocculonodular lobe and lingula, which is connected to the nucleus fastigius, and it has chief connections to the vestibulocerebellar pathway and has function in maintaining of equilibrium. Whereas paleocerebellum is in between, that is neither the oldest nor the newest, where the whole of the anterior lobe is involved, and it has the nucleus interpositus consisting of nucleus globus and emboliform, and it has connections with the spinocerebellar pathway, and it controls crude movements of the lip. The neocerebellum is the most recent one. It is constituted by the whole of the posterior lobe and the lateral lobes of the cerebellum, and the nucleus connected to it is the dentate, and it has chief connections outflow tract to the corticopontocerebellar fibers and helps in smooth voluntary movements. Coming to cerebellar cellular anatomy and organization, the chief afferent input to the cerebellum is through the mossy fiber and the inferior olive. The mossy fiber gets its fibers from the brainstem as well as the cortex, and the inferior olive gives the fibers for the climbing fiber, gives the input for the climbing fibers. These mossy fibers and climbing fibers finally helps in giving excitation to Purkinje cells via various pathways in the molecular structure. That is, the final output is via the Purkinje cell. There are the mossy fibers transmit through the intermediate granule cells. These granule cells, reaching the molecular layer, give parallel fibers which connects with the arborized branches of the Purkinje cell. Whereas the inferior, these climbing fibers from the inferior olivary nucleus synapses directly with the branches of the Purkinje cell. In addition, there are other interneurons like brush cells, Golgi cells, and basket cells, as well as stellate cells, most of which are inhibitory. And this Purkinje cell output modulates the deep cerebellar nuclei. So these are the schematic representation of deep cerebellar nuclei. And the Purkinje cell output, it modulates the deep cerebellar nuclei, which are the dentate, interpost, and fastigial. They have interconnections between them, as well as gives efferent connections to the brainstem, as well as the cortex, as well as the reticular formation. So the chief afferent pathways to the inferior cerebellar peduncle include the olivocerebellar, vestibulocerebellar, reticulocerebellar, posterior spinocerebellar, trigeminous cerebellar, cuneocerebellar, and arcuatocerebellar fibers. Whereas efferent pathways are the cerebello-olivary, cerebello-vestibular, and cerebello-reticular. Middle cerebellar peduncle is composed of the pontocerebellar tract, which is the single afferent tract from the cortex. And the superior cerebellar peduncle is composed predominantly of efferent pathways, that is from the cerebello-rubral fibers and the dendritothalamic fibers, along with fastigio-reticular fibers, whereas it can have small afferent pathways like anterior spinocerebellar tract and tectocerebellar tract. So we have seen cerebellum is multisynaptically and reciprocally connected to large number of cortical as well as subcortical regions. And it has dense connections to the motor nucleus, cerebral cortex, as well as basal ganglia. And all of these cerebellar nuclei, not just the dentate, all of these cerebellar nuclei project to the cerebral, has its role in projecting to the these areas. Coming to cerebellar function in health and disease. So whenever cerebellum is in disease, it manifests as clinical features. It includes gait abnormalities whenever there is midline damage, ataxia in ipsilateral limbs when there is hemispheric lesion, impaired rapid alternating movements or dysdiadochokinesia in hemispheric lesions. There can be gait veering towards the lesional side in hemispheric and midline lesions, intention tremor, dysmetria, slurred speech, impaired gaze, fixation, pursuits, and broken pursuits, nystagmus, reduced muscle tone, pendular reflexes, urinary symptoms, bladder instability. And these all are features of cerebellar dysfunction. And it has also roles in cognition and affect. That is, if cerebellum is involved, it impairs executive function, visuospatial cognition, language, and emotional regulation as well. There is an entity called cerebellar cognitive affective syndrome, where it is a cognitive counterpart to motor dysmetria, where patients with their cerebellar disorders display impulsive and compulsive behavior, along with depression, anxiety, fatigue, and sleep disturbances. This can be attributed to the reward processing role of cerebellum, which is involved in the CCAS as well as associated behavioral issues associated with cerebellar disorders. So cerebellum is implicated in various disorders like neurological, neurodevelopmental, including autism and ADHD, as well as psychiatric disorders, including schizophrenia and epilepsy. So coming to cerebellum in epilepsy. So in epilepsy, cerebellum can be involved via the use of anti-seizure medications, falls associated or trauma associated with seizures, or genetic etiology that is responsible for the seizures. The treatment-resistant epilepsies are found to have more cerebral and cerebellar damage in epilepsies. And in studies in temporal lobe, epilepsies shows ipsilateral cerebral atrophy even without phenytoin. It is not that chronic phenytoin use is associated with ataxia and cerebellar atrophy. It is via the Purkinje cell toxicity and leading to cerebellar degeneration. And in TLA patients with hippocampal sclerosis, chronic phenytoin use can lead on to posterior lobe atrophy. And in phenytoin as well as other voltage-gated sodium channel blockers can also cause dose-dependent ataxia. In IG, valproate can lead to cerebellar volume loss and tremors. In TLD patients with hippocampal sclerosis, chronic phenytoin use leads on to posterior lobe atrophy, which is evidenced by the yellow color, orange and yellow color. Coming to structural and functional neuroimaging, giving evidence for cerebellar involvement in epilepsy. And there is a study called Enigma Epilepsy Study, which studied patterns of subregional cerebellar atrophy across epilepsy syndromes. In this study, they quantified the cerebellar lobule volumes using structural MRI in 1,602 adults, which was compared to 1,022 healthy controls, who were selected from the Enigma Epilepsy Working Group. And they used a deep learning approach where automatic cerebellum anatomical parcellation using UNIT with locally constrained optimization. Acapulco, it is a deep learning approach. It used a deep learning algorithm to automatically parcellate the cerebellum into 28 anatomical subunits, and they compared the volume between the epilepsy patients and healthy controls. They compared healthy controls with all epilepsies, temporal lobe epilepsy with hippocampal sclerosis, non-lesional temporal lobe epilepsy, genetic generalized epilepsy, and extratemporal focal epilepsies. And finally, they found that a reduced cerebellar volume was found across all epilepsies. And maximum volume loss in all epilepsies was found in corpus medullaire and the posterior lobe gray matter regions, including the lobules 7B, CRUS 1, 2, and 8B, 8A and 8B in all epilepsies. And along with that, earlier age of onset and longer epilepsy duration was also correlated with reduced volume in these regions. And associated phenytoin treatment was associated with increased reduced posterior volume. And cerebellum volume also correlated with cerebral cortical thinning in epilepsy cohort rather than in controls. Here we can see the yellow or the orange shaded regions show more atrophy. In temporal lobe epilepsy with hippocampal sclerosis, it is seen the more posterior lobe atrophy, whereas it is minimal posterior lobe atrophy in generalized epilepsy. In extratemporal epilepsy, also predominantly posterior lobe atrophy seen. Ictal SPECT studies, the SPECT, as you all know, measure regional cerebral blood flow, helps to localize the epileptogenic zone and helps in supporting lateralization and differentiate ictal versus interictal states in epilepsy. So in cerebellum, there can be a cross-cerebellar diaschisis. It is thought that cerebellum, there will be reduced flow in the hemisphere contralateral to the supratentorial seizure focus. That is via the mediated by the corticopontocerebellar pathways, which lead to functional suppression of opposite cerebellum. But the ictal SPECT studies have found contralateral hypo as well as hyperperfusion, which is reported in various SPECT studies. Coming to PET studies assess cerebellar metabolism in epilepsy. In TLE, interictal hyper as well as hypometabolism in cerebellum has been reported. In patients with high risk of SUDEP, there is increased metabolism in bilateral cerebellar vermis and deep cerebellar nuclei, which is reported. And cerebellar functions are modulated during epileptiform activity and suggest a functional significance of temporal cerebellar connections in the disease. Functional MRI studies have also helped to identify the cerebellar functions. By functional MRI studies, we understand that there is an anterior motor and posterior non-motor predominance. That is functionally distinct cerebellum has functionally distinct connections, which divide it into anterior motor and posterior non-motor areas. Anterior lobe and the lobule 8 handle sensory motor tasks. Posterior hemispheres link to attention and default mode networks. And emotional processing maps to lobule 7 and 9, 8 medially. Here we can see with various color codings, they have picturized the functional MRI in cerebellum. We can see anteriorly there is the somatomotor network, whereas posteriorly the red is the default mode network and the dorsal attention network, which is marked by the green. Coming to neuropathology of cerebellum in epilepsy. Initially, to find out the role of cerebellum in epilepsy, there was patient and animal models which demonstrated structural changes in cerebellum. And initially, studies were done in genetic epilepsy prone rat and Wistar audiogenic rat, where they demonstrated midline cerebellar structure volume loss. which later led on to studies in neuropathological changes in cerebellum in epilepsy. And it is thought that anti-seizure medications, hypoxic ischemic injury, trauma, as well as genetic cause can lead on to cerebellar atrophy. And histopathologically, it is shown that they will have Purkinje cell loss, which is being uh, taken over by the Bergman cells, leading on to Bergman gliosis, which leads on to structural alterations, leading on to impaired neural communication, leading on to seizures. So, cerebellum. Initial studies have found a pattern of cerebellar atrophy in various epilepsies, in various conditions. That is, whenever patient is having a poor seizure control, it was thought to have an anterior atrophy and posterior atrophy, mostly associated with head injury. And histological changes that we see include Purkinje cell loss, which leads on to Bergman gliosis and later structural alterations. There can be torpedo-like axonal swellings, which may be seen in the cerebellum, granule cell damage, cerebellar white matter changes, as well as dendrite nucleus neuronal loss. In various disorders of the cerebellum, there can be various histopathological changes. There is gray matter loss has been reported in SUDEP. Cerebellar dysgenesis has been observed in sudden unexplained death in childhood. Cerebellar maximal atrophy has been seen in epileptic encephalopathy. Purkinje cell loss and progressive cerebellar cortex atrophy has been seen in progressive myoclonic epilepsies. And in patients with opsoclonus myoclonus ataxia syndrome, it was found that peak cerebellar volume was attained earlier than normal subjects. That is at 7 years when compared to 13 or 16 years in normal subjects. Coming to epileptogenic lesions of cerebellum. The epileptogenic lesions, that is, lesions in cerebellum that contribute to epilepsy, usually are asymmetric, benign, or low-grade tumors located in the floor of the fourth ventricle, and they usually involve the peduncles, so that the major outflow path from the cerebellum that is involved, and helps in and causes the spread of the ictal activity to the brainstem or the descending motor or the autonomic pathways. And the common epileptogenic lesions associated include gangliogliomas, gangliocytomas, ganglioneurocytomas, hematomas, and low-grade or pilocytic astrocytomas. And the seizures in cerebellum associated, epilepsy associated with cerebellar epileptogenic lesions usually include focal motor, autonomic, and occasional focal to bilateral tonic-clonic seizures, which typically present in infancy with hemifacial clonic or tonic seizures ipsilateral to the cerebellar mass. And 1/3 of the patients present with motor seizures on the first day of life, and more than 80% of them present before the age of 1 year. And onset after the age of 4 years is uncommon. And as I've already mentioned, they are hemifacial motor seizures, which affect more than 90% of the patients, which maximally involves the orbicularis oculi and causes blinking with variable lower facial involvement. And there can be eye deviation ipsi or contralateral to the facial motor activity. And other features include there can be associated head deviation, tonic-clonic movements, bilateral myoclonus of proximal extremities, autonomic signs, affective changes, vocalization, impaired responsiveness, automatisms, as well as tonic-clonic convulsions. EEG findings can be normal or can show non-specific slowing, sometimes lateralized to the side of the cerebellar lesion. And ictal scalp recordings can be unrevealing sometimes, but intraoperatively, when using depth electrodes, ictal and inrectal epileptiform discharges may be seen, and rhythmic theta or delta activity can be seen in gangliogliomas as well as hematomas. And these lesions are typically resistant to ASMs, and especially when sodium channel blockers are thought to cause cerebellar degeneration. So, in these cases, to be used in caution. And total resection of lesions can lead to seizure freedom. Sometimes partial resection can also cause reduction in seizure burden. And since this after surgery on follow patients, most of the patients develop more normal milestones and intelligence, although prolonged follow-up is necessary. And the post-surgical complications may include facial or extraocular muscle weakness, nystagmus, weakness, ataxia, or tremor affecting the ipsilateral upper extremity. Coming to a case, this is an 18-year-old girl with normal birth and development without any antecedents, had seizures from 10 years of age of semiology, nausea followed by behavioral arrest, stare, postictal confusion, and some episodes with bimanual automatisms with an initial frequency of 1 to 2 per day. She was tried on valproate initially, later by oxcarbazepine, clobazam, and lacosamide. Her EEG showed IEDs like PHR, left temporal, bilateral PHR, frontal spike and wave discharges, and with burst attenuation patterns. And this was the ictal recording. There is a stare followed by right eye deviation. There is movements of the upper limb also, but it is not chewing automatisms. There is a sudden stare with eye deviation to right. There is tonic neck flexion, as well as there is chewing movements of the possible upper limb automatisms as well. No, extratemporal, sir. Sir, neck and eye deviation, early eye deviation is there. Temporal. So initially there is eye deviation and tonic flexion, so more suggestive of extratemporal semiology. So this was the ictal recording. It showed a diffuse ictal onset. MRI of the patient showed a T2 flare hyperintense lesion in the left lobe of cerebellum with a minimal hyperperfusion in ASL. And this was a cerebellar hematoma, currently on ASMs, planned for surgery. Coming to neuroinflammation and epilepsy. The cerebellum may be involved in infectious, post-infectious, post-vaccination, paraneoplastic, and as well as autoimmune CNS inflammatory disorders associated with seizures and epilepsy. And cerebellum cerebellum in these conditions as the primary site of epileptogenesis is not defined. And the role in seizure initiation and propagation in such conditions also are ill-defined. But seizures can be associated with neuroinflammatory syndromes associated with cerebellar involvement. And these immune conditions include MS, acute cerebellar ataxia, paraneoplastic causes of cerebellar degeneration, autoimmune cerebellar ataxia, viral encephalitis involving cerebellum, post-infectious cerebellitis, Bickerstaff's encephalitis, cerebellar sarcoidosis, autoantibody syndromes involving the Casper2, anti-CV2, anti-DPPX, GAD65, and gliadin, that is celiac disease associated, anti-WHO, anti-LGI1, mGlu-R1, MA2, right? And can be associated with anti-SSA as well. Other ones include anti-TG2, TR, VGCC, anti-O. Post-infectious cerebellitis can also present with seizures. Then there are other bacterial and viral causes as well. Acute cerebellitis with seizures can be managed by management of the underlying cause, corticosteroids, rarely decompressive surgery or for imminent herniation, and as well as acute and chronic ASMs later if necessary. Chronic autoimmune paraneoplastic cerebellitis can be treated by immune modifying therapy as well as underlying malignancy if present. Coming to genetic epilepsies with cerebellar involvement. Cerebellum contains more than 50% of all human brain neurons. So, monogenic epilepsies, more than 900 monogenic epilepsies are reported. So, the cerebellar involvement in monogenic epilepsies may be higher with varied pattern or varied involvement. And so, so it has role in seizure, motor, cognitive, as well as behavioral disorders. Yang et al. Studied cerebellar atrophy in genetic epileptic encephalopathies in a cohort of 67 children with developmental epileptic encephalopathy, where they found 10 had cerebellar atrophy, 6 had cerebellar signs. 4 of them had TBC1ID4D24, 1 had ARV1, CAD, KCNA2, SCN2A, WDR72 mutations. And they recommended finding these many mutations. They recommended that cerebellar atrophy should be considered as an indicator to carry on genetic testing earlier in patients with epileptic encephalopathy. In their cohort, a patient's SCN2A was found to have cerebellar atrophy along with cerebral atrophy with hypoplastic corpus callosum and white matter abnormalities. And the one with SMC1A mutation had isolated cerebellar atrophy. And they also did a systematic review of all articles showing cerebellar involvement in genetic epilepsies and found maximum association with tubulinopathies as well as other channelopathies also being involved. And the other genes include UFM1, CACNA1A, KCNC1, then KCNA2, ARV1, TBC1D24, SCN2A, SMC1A, etc. And they have studied the genes related to isolated cerebellar atrophy and the genes that are related to cerebral atrophy with other brain anomalies, as well as early and late onset cerebellar atrophy. And they have found that ion channel associated genes associated with ion channels was more associated with isolated cerebellar atrophy. And late onset cerebellar atrophy was also more associated with ion channels and regulators of gene expression. In Dravet syndrome, cerebellar dysfunction contributes to seizure, ataxic gait, and cognitive involvement, cognitive affective disorders in Dravet. And Dravet is usually caused by truncating and loss of function mutation of SCN1A. But SCN1A is more expressed in the cerebral cortical than the cerebellar regions. In SCN2A, it is expressed slightly more in cerebellum, so will have more cerebellar atrophy than SCN1A. And the pathology is in Dravet, there is involvement of the parvalbumin interneurons and the Purkinje cells, leading on to Purkinje cell loss and leading on to cerebellar atrophy. Coming to progressive myoclonic epilepsies, these are rare and heterogeneous disorders where there is myoclonic and epileptic seizures and progressive neurodegeneration that leads on to dementia, ataxia, neuropathy, and myopathy. But these are heterogeneous disorders. They can have variable presentations and family patterns. And cerebellar involvement in PME is by maximal neuron loss in Purkinje cells, Bergman gliosis, and loss of granule cells. And in MRA and neuropathology, there will be cerebellar atrophy, and patients can have cerebellar signs like ataxia, dysmetria, intention tremor, and dysarthria. So these are the PME syndromes. Myoclonic epilepsy with rag-red fibers, Lafora disease where there is involvement of EPM2A or 2B, Unverich-Lundborg disease, cystatin B, Sialidosis, North Sea PME, Farber's disease, NCL, then progressive myoclonic epilepsy 9, DRPLA, PME ataxic syndromes. Others like type 3 neuronopathic Gaucher's has Tay-Sachs also comes under PME syndromes. And usually these are of partially controlled by ASMs. Usually used ones are benzodiazepines, levetiracetam, riveracetam, perampanel, valproate, along with diet modification and neurostimulation techniques, if refractory, like including TMS, vagal nerve stimulation, DBS. And in some cases, sodium channel blockers may worsen myoclonus. And the future is in enzyme replacement and the ASO as well as targeted drug deliveries and gene editing, etc. Coming to a case, this is an 8-year-old girl from Tamil Nadu, born of third degree consanguinity, with presented with gait difficulty with imbalance from while walking from 2.5 years of age, with bilateral upper and lower limb tremulousness. She had associated generalized seizures and atonic falls starting from 4 years of age. On examination, she had scanning speech, impaired finger, nose, and heel knee test with ataxic gait. And EEG showed left centroparietal spikes with marked activation and sleep, some with frontal positivity and along with right occipital IEDs. And multiple right leg EPCs were recorded with the correlate of left centroparietal spike and wave discharges. The MRI of the patient showed cerebellar atrophy, minimal cerebellar atrophy along with cortical atrophy. And she, on genetic testing, on whole exome mitochondrial testing, was found to have autosomal recessive homozygous missense variant in exon 2 of KCTD7G. Coming to cerebellar stimulation to treat epilepsy. As we've already described, cerebellar cortex sends signals or integrates its input to the deep cerebellar nuclei, which is projected to various parts of the neuraxis, that is the thalamus, superior colliculus, amygdala, reticular formation, which are involved in seizures as well as seizure related activities. So cerebellar stimulation has been thought as a site or target to treat epilepsy. So it has been studied extensively, but currently it has found that it is of uncertain efficacy, that is inconsistent results with animal and human models, and the results can vary based on change in target stimulation parameters, temporal or cell type specificity, based on the different models or different studies they are using. And common targets studied include cerebellar vermis and vestigial nuclei, which in limbic epilepsy models were found to be effective. In generalized epilepsy models, stimulation of the lateral and intermediate nuclei was found to be effective. The excitation of deep cerebellar nuclei appeared to be inhibit seizures across focal as well as generalized models. And the closed loop modulation of Purkinje cells is found to attenuate hippocampal seizures in TLE models. And vestigial nucleus excitation was also found to reduce seizures. These are various cerebellar stimulation trials, where initially started with cortical stimulation, where the initial cortical stimulation in animal models was found to synchronize and desynchronize EEGs. So it started with cortex. Later, it had positive as well as negative effects in various trials. Recently, the use of optogenetics and closed loop cerebellar stimulation, that is closed loop means during identifying the epileptic activity and the stimulating, that cerebellar stimulation helps in precise seizure control. And so in the closed loop models, high frequency vermis stimulation worked in TLE mice. And why open loop could worsen seizures, and they had found various side effects associated with that. So closed loop settings were found to be more safe and tried later on. And the complications following this cerebellar stimulation experiments include infections, electrode displacements, intracranial hemorrhage. Even though these animals and human models support the potential efficacy, more research is needed to identify the optimal candidates, anatomical targets, ideal anatomical targets, as well as stimulation parameters by using well-powered randomized control trials. This is a pictorial representation of optogenetic stimulation of the cerebellar nuclei. This is a model of absence epilepsy, where the cerebellar nuclei stimulation lead on to. We know that the connection with the thalamus is involved in absence epilepsy. So, optogenetic stimulation of the cerebellar nuclei in mouse models of absence epilepsy, where these closed loop stimulation led on to terminating of generalized spike and wave discharges. Coming to comorbidities associated with seizures, which are influenced by cerebellar involvement. We know 99% of all elderly individuals are taking ASMs, even for non-seizure indications. And ASM use has increased the risk of falls from 1.3 to 1.6 folds over the controls among various studies. And with ASMs, the relative risk of falls ranges from 1.75 to 6.2 for a single fall to 2.6 to 7.1 for multiple fall. So ASM levels, whenever we are giving, it can peak at some time. It can peak and it can lead to unsteadiness, especially if at night, if patient is getting unsteadiness, there is tendency to fall. And ASM side effects are the major contributor to falls in epilepsy patients. And so, use of extended release ASMs, taking morning medications after breakfast, and other ways to avoid high peak levels can reduce the risk of falls. And a seizure related fall signals an increased risk of future falls. So, falls associated with ASMs to cerebellar dysfunction caused due to epilepsy, to the seizure associated fall. So, all these can lead on to fall. So for prevention, we have to use the strategies already mentioned. Another common comorbidity associated or morbidities associated with epilepsy is SUDEP. And sudden expected death in epilepsy, the underlying process, the final underlying process is sudden unexpected death in epilepsy. The processes underlying SUDEP remains elusive, but circumstances surrounding SUDEP suggest a centrally mediated cardiovascular or respiratory collapse following a GTCS. And brainstem nuclei like the pre-Botzinger complex are found to be critical in respiratory control. Also, there are other autonomic network structures that contribute to respiratory and cardiac failure in SUDEP. The fastigial nucleus in cerebellum also contains respiration modulated neurons sensitive to carbon dioxide and H plus ions. This was a study done by Allen et al. The cerebellar, limbic, and midbrain volume alteration in SUDEP was found. And 25 SUDEP cases were retrospectively imaged with controls with identical high resolution T1 weighted scans. And the regional gray matter volume was determined by voxel based morphometry and segmental derived structure sizes and were compared across the groups. And the regional gray matter volume loss in SUDEP compared to healthy controls was seen in bilateral cerebellum, vermis, posterior cingulate, periaqueductal gray, and left posterior and medial thalamus. And these substantial loss of cerebellar volume in patients with SUDEP and those at high risk of SUDEP finally led to us to a conclusion that cerebellum is essential to recover from a compromised cardiovascular and breathing disturbances that happen during a SUDEP or post GTCS. And cerebellum is important in responding to the hypercapnia and modulation of breathing. And this periaqueductal gray and bilateral posterior cingulate also shows tissue loss. These sites are also these sites also project to cerebellum and helps in maintain blood pressure integrity following a seizure. And in SUDEP, the volume increase was noted in some sites like amygdala and subcallosal cortex, which can trigger apnea and hypotension as well, which more prominently in SUDEP. Even though SUDEP and AEDs, the high-risk subjects and SUDEP had been tried on greater number of AEDs, whether AEDs or combination AEDs are responsible for SUDEP, it is not being finally concluded or elucidated. So, people with epilepsy they'll be exposed to, already will have genetics which are make them prone to epilepsy as well as cerebellar dysfunction. They'll be taking ASMs that can lead on to cerebellar dysfunction. They will experience seizure, especially GTCS or seizure related fall or trauma. All these can contribute to cerebellar dysfunction, which can be seen in imaging, in pathology, as well as PET SPECT studies. And this can manifest, the cerebellar dysfunction can manifest as cerebellar signs, including ataxia, tremor, nystagmus case in abnormalities, speech deficits, as well as it can contribute to falls and SUDEP. That's all. Thank you. Network epilepsy. Involving epilepsy network connections.
By religion or by genetic condition. And that causes symptoms. So what are the other structures that can actually cause?
Thalamus.
Right, the thalamus.
Everything.
Thalamus causes what kind of eclipse? Thalamus causes. Yes.
Absence. Absence. Absence.
Right. You talk about critical genetic generalized complexes, they are believed to be particle subparticle. You know, there are particle mechanics, challenge. Other structures which can cause again white vibrations cause epilepsy. Subparticle, white vibrations. They cause subparticle epilepsy. Or a contagious quality.
Usually
Only the camera mobile
can cause.
right. Right, that true. It's an isolated deep nuclear lesion on discuss this white vibrations. There has to be a concurrent white vibrations one source of this. What is the precise example of cardiac or a beta eclipse? What you get in the context of rasmus, that's like cardiac involvement is part of the network. Unlikely that isolated deep nuclear lesions. So when it comes to cellular involvement also, you cannot say that isolated white matter of the cellular or isolated deep nuclear cellular lesions can cause epilepsy. How does it modulate epilepsy? How does it cause?
So cerebellum has outflow tracts and cerebellar nuclei has connections.
Right.
Dendrito-rubrothalamic
Max?
tracts involved. From dendrit, all cerebellar nuclei can brainstem therapy. Dendrit, globus, fastigial, and emboliform. Fastigial, globus, emboliform.
What are the rare?
Cortex, white matter.
No.
Molecular layer, Purkinje cell layer, and deep superficial. Molecular layer. Purkinje cell layer. Granule cell layer. Through the Purkinje cells. Purkinje cells. Deep nuclei. Through the deep nuclei. Inputs by cell. Corticopontocerebellar. Corticopontocerebellar.
Pontocerebellar. Right.
through, through mossy fibers. No.
Right.
Through the mossy fibers granule cell layer to the molecular layer and Purkinje cells. Climbing fibers.
That is how you have the knowledge all the context and inputs coming into the cerebellum practice. Now it was initially thought that have particle physics can produce inputs into cerebellum fluids. But now it's understood that there are networks. So you mentioned about the networks can cause cerebellar involvement. So primarily the default mode network as well as the
Attention networks.
are these networks.
Resting state and cognition scan. Basal ganglia. And
Same level of patients it is believed that there is dysfunction involving default mode or that's a hypocorrect involving the default mode. That hyperconnectivity is down-regulates the inputs into the circuit. Basically, the default mode network is an important network when it comes to self or either attention. Basically, awareness of self. If you just close your eyes, it's the default mode network. And also, attention network is more of a frontal parietal. Have the frontal lobe, premotor areas at the brain, and that it becomes active when you sort of attention to a task. Extroceptive confinement. Proceptive attention is through the salience net. It's called the salience net. Salience net is a
scan.
corner. It decides as to which stimuli in the environment your body or needs to attend. It gives awareness to your body to react to that. So these are all new concepts, and it's not as isolated cortical areas, but have networks which impact other areas of the brain. And these networks are intricately connected to the cerebellum. The molecular impact, the cell gives its own, but that's kind of the Purkinje cells. It sort of gives it out of the deep nuclear connected brain stem cell. The cerebellar epilepsy is typically, if you see, even within the cortex, it has to doesn't involve the deeper parts of the cerebellum. They are primarily involving for the granule cell. So they can either involve the location of
Peduncle.
can be anywhere, can either be in the neos or it can even be in the RP side, that is the parallel. But usually the lesion is okay. And then the out, so in the deep nuclear, that deep nuclear is suspected process. Just the reason why, because of the intricate connections of the nuclear in the brain stem and the nerves, you get non-lateralized seizures. Seizures may not be particularly non-lateralized. Can be some temporal-like seizures, as you saw in that patient, started off with an extra temporal seizures, then kind of focal temporal-like manifestations. All that is because of the fact that you get these cortical pontocerebellar targets. They are not typically, they may not produce typically lateralized sites because of they manifest by virtue of connections to the brain and other neurons. Similarly, this cross-cerebellar diastase is an important entity when it comes to perinatal lesions. Cells which happen in the brain period as well as the present. If they are long-standing, by virtue of the cortico-pontocerebellar pathways, they cross this cross-circular diastasis. And this cross-circular diastasis, this does not preclude surgical selection. Once you identify that, you know that the network from one hemisphere has all the contralateral segments. And those patients, if you disconnect the hemisphere and the patient has a registered epilepsy, it is not going to cause a decline in the right. In fact, cause a feed forward inhibition, which happens cerebral sort of stops. It's not that the cerebellar dysfunction in cross cerebellar diastasis can progress, and patients can improve most of its slowly. Regarding the impact of anti-seizure medications, why do older anti-seizure medications affect cerebellum than among the newer ones like among the major comes to mind? Comparison to that, why do the older anti-seizure medications traditional pedigree complicity? And that's with the extent of involvement of the fast activating as well as the slow inactivating sodium channels. Basically, most of the older anti-seizure medications are not very channel specific as opposed to the amlodipines. Focus on fast acting. The sodium channel, the lacoside, that's the slow inactivating sodium channels. These ones are not very specific. That's why that you get cross involvement of the T cells, which is the main output neurons of the cell. That is why Purkinje cell degeneration happens in many conditions. It's not only epilepsy related or anti-epileptic drug related side effects, but also in autoimmune conditions. Patients with XTA encephalitis substance or to that Purkinje cell loss. So basically, most of the activity is the involvement of the output neurons. And the modulation is very disappointing when it comes to this, primarily because of the fact that you can modulate generalized epilepsy to some extent, but focal epilepsy will be very important. One of the mechanisms by which the EMS also acts need to be cerebellar modulation. So EMS gives it puts it the medulla subsequently has rich connections. That is which part of the medulla is connected to cerebellum.
Medulla.
Yes. Yes.
Say inferior cerebellum. Inferior olivary.
And so, the EMS inputs which come from the various protocols is that can be inputs in the granule cell layer that can modulate. Remember that the cellular complex effect is also was described by virtue of these connections in the cortical oncosensory pathways. Features on the cell can produce cognitive affective symptoms, just picking what kind of
This preference. Sleep problems.
sleep problems. Maybe cognitive sex. See a patient with epilepsy and you see cerebellar volume loss. These will be problems. One thing is whether this is anti-seizure medication you're used to. The other is whether there's a therapeutic condition.
Associate.
Patient has either traditional sodium channel blockers. Typically, long-standing use is one of these. But acute toxicity can also lead to reversal. It's tough after the sort of direct cell harm after cutting the two tablets right after sleep. The cerebellar volume loss which happens is progress reverse and we reverse. In terms of cerebellar effect, quickly you might see we'll see that they have persistent PG cell. And certain metabolic conditions are also known for metabolic conditions which you can see associated with cerebellar lesions are typically labeled during disease. Phenol ketonuria and methyl malonic acid, organic acidias, and organic cryoseptics, along with cerebellum. Then you can see diffusion restriction lesions involving the areas. Similarly, mitochondrial disease. Again, it's primarily the output PIDs which are showing diffusion restriction. There are a lot of things which you can look at, and cerebellum can provide you that effect. Like so, for when you are showing the phenotyping, the genes, talk about the particular genes and all those things. Apart from brainstem malformations, they can also cause cerebellar abnormalities.
Dysgenesis.
These would all be indicators that you are dealing with an underlying
Genetic.
condition. You see a first obvious would get scared. You are seeing a market for patients.
Thank you all. We are winding up this session.